Theory Seminar Group 6 by Maya Gibson, Shari Melvin, and Kayla Wells. Nursing 6301, Theoretical Basics for Advanced Nursing Practice, Winston-Salem State University, Dr. Katie Faust. Nursing Theories and Models. Florence Nightingale introduced the idea of using analyst techniques to assess problems within healthcare systems and initiate plans of improvement. Dahlgren and Whitehead Rainbows Model. In 1991, Göran Dahlgren and Margaret Whitehead developed the Rainbow Model, which focuses on social determinants of health, explaining how various layers of influence interact to shape health outcomes. The public health theory evolved from Nightingale's sanitation work, social reform, epidemiology, and Lillian Ward's community nursing.
In this slide, we will discuss the origin of our theories and theorists. To begin, we will talk about Florence Nightingale, who was born in 1820. She was a well-known contributor to healthcare during the Crimean War. Her meticulous work led her to conclude that most soldiers were actually dying as a result of diseases acquired through the horrific hospital conditions rather than battle itself. She decided to keep record of her speculations, which highlighted that causes of death were contamination, lack of supplies, and disorganization. She began to work alongside the Sanitation Commission and some of the surrounding nurses to improve the quality of hospital conditions, thus reducing death rates dramatically. Her statistical analysis techniques have been adopted by modern healthcare by way of pie charts. Pie charts are used to illustrate relationships between identified problems and outcomes. It is also the starting point for initiating plans for improvement influenced by factual data, and a way to measure the quality of patient care through the evaluation of results. Secondly, we will discuss Dahlgren and Whitehead's Rainbow Model. The Rainbow Model emerged from research on health inequalities, showing that differences in health were largely shaped by social and environmental conditions, not just medical care or individual behavior. It was created to provide a conceptual and visual framework to help policymakers and health professionals understand that most health inequalities stem from social and structural factors beyond individual control. This model emphasizes that improving public health requires addressing these wider determinants, not just promoting individual behavior change. Our third theory is the public health theory, and it does not have a single creation date. Historically, these ideas began to take shape in the mid-19th century through sanitation reforms by Florence Nightingale, epidemiology by John Snow, and later evolved into public health nursing theory with Lillian Wald's community nursing work in 1893. In this slide, you can see the similarities between all three of our theorists and models. As a group, we have determined that there are three common themes and concepts that all three of our models share. Those include patient-centered care, advocacy, and providing quality care.
Now let's discuss the differences in each theory. The Nightingale theory includes the collection of data, focuses on improvements based on gaps or barriers, displays results via visual aids. The Rainbow Model utilizes age, sex, and constitutional factors as its core. Last, the public health theory focuses not just on individuals, but on populations, communities, and systems. Also, it addresses the environmental factors as well.
We will now transition into discussing the key concepts of each theory. To begin, Nightingale's approach to quality improvement focused on 4 key concepts, the first being defining quality care. According to Patsy Anderson, who is the author of Chapter 15 of our text, Nightingale described quality care as the absence of factors that hinder the reparative process of disease. This means that defining what quality care means to you will help guide the type of care you give and assist you in determining your care goals. Additionally, in order to have a successful healing journey, basic human needs must be met. These include things like fresh air, food, water, appropriate living environments, and spaces suitable for peace. Anderson also spoke on Nightingale's request that nurses be conscious of their behaviors. These behaviors include rustling noises and chatter, and were considered irritating environmental factors for the patients. Nightingale heavily focused on obtaining clear, detailed clinical data for the improvement of patient outcomes. This is what led to her discovery of useful interventions and solutions to hospital problems. Her work resulted in the reduction of many deaths, and in 1856 she was formally requested by the British Secretary of State for War to use her analysis techniques and document the conditions of sanitation and medical treatments of soldiers in Crimea. This job led to the development of visual aids. Nightingale first developed the polar diagram to document the number of soldiers who died in battle versus iatrogenic hospital causes. Today, we have adopted similar charts, such as pie charts, to visually express collected data and brainstorm methods for improvement. This is also a great way to evaluate effectiveness of interventions and display patient outcomes. In the photo to the left, you will notice a polar diagram behind Nightingale.
The next model that we will discuss is the Dahlgren and Whitehead model, often called the rainbow model. It illustrates the social determinants of health and how multiple layers of influence affect a person's health outcomes. The model emphasizes that health inequalities arise from the interaction between personal characteristics and wider determinants. The age, sex, and constitutional factors serve as the core of the model, focusing on innate individual characteristics to include genetics, biological sex, and age. These factors influence susceptibility to disease but are largely non-modifiable. Next is the individual lifestyle factors layer, which focuses on personal behaviors and choices such as diet, physical activity, smoking, alcohol use, and sleep habits. These are the most direct, modifiable influences on health. Next is the social and community networks layer, which focuses on relationships and social support to include family, friends, peers, and community connections that influence well-being. Having strong social ties can improve mental health, encourage healthy behaviors, and promote emotional or practical support. The living and working conditions layer focuses on everyday environments that shape health and covers access to education, employment, housing, healthcare, transportation, clean water, and sanitation. It also includes workplace conditions, food availability, and neighborhood safety. These major social determinants of health are often beyond an individual's direct control. The general socioeconomic, culture, and environmental conditions layer is the outermost layer of the model and focuses on broad structural factors in society. This layer encompasses economic policies, cultural norms, political systems, environmental conditions, and social inequalities. These factors set the context of which all of the other layers exist, such as a country's income distribution, gender norms, or climate change policies. Next, we will discuss how some key concepts of Dahlgren and Whitehead's rainbow model apply to advanced nursing practice. The model focuses on holistic, person-centered care, community and environmental focus, health equity and advocacy, and preventative and upstream approach. For holistic, person-centered care, health outcomes depend on more than biology. Social support, education, housing, and employment play major roles. As an advanced practice provider, this can be implemented by integrating screening for social determinants of health and coordinate care that addresses these broader needs. For community and environmental focus, advanced practice providers incorporate the outer layers that highlight that communities, workplaces, and policies shape population health by collaborating with community organizations, advocating for safe environments, and participating in health promotion programs. For health equity and advocacy, the model underscores that inequalities arise from structural and policy level conditions. In an advanced practice role, it is imperative to advocate for policies that reduce disparities and ensure equitable access to care. For preventative and upstream approach, advanced practice providers can improve health by addressing root causes rather than only treating illnesses, by utilizing data and evidence-based interventions to design preventative strategies and promote long-term community wellness.
The public health theory focuses on the health of population rather than just individual patients. It integrates nursing science, public health principles, and social sciences to prevent disease, promote health, and protect communities. The goal is to create conditions in which people can be healthy through education, policy, environment, and access to care. Utilitarianism promotes actions producing the greatest good for the greatest number. These policies may inconvenience some individuals but are justified if they prevent greater harm or produce greater overall benefit. An advanced practice provider uses utilitarian thinking when making population-level decisions where collective benefit outweighs individual preference. It supports equitable resource allocations, like prioritizing high-risk groups during an epidemic. Theory of justice. Justice ensures that health resources, opportunities, and burdens are distributed fairly, not based on privilege, race, or income. It underpins advocacy for vulnerable populations, addressing social determinants of health like housing, education, and access to care. With precautionary principles, let's first think do no harm. If an action or policy has a suspected risk of causing harm to the public or environment, and scientific consensus is uncertain, precautionary measures should be taken. This promotes prevention over reaction. It supports ethical decision-making when evidence is incomplete but risks are potentially serious. Beneficence, the ethical obligation to do good and promote the well-being of individuals and communities, is essential to advanced practice public health nursing. As an advanced practice provider, applying beneficence means prioritizing interventions that prevent disease, reduce harm, and enhance quality of life at both the patient and population level. In public health, beneficence extends beyond clinical treatment. It includes advocating for equitable access to services, addressing social determinants of health, and developing programs that improve community outcomes. Subrogation is acts that go beyond duty, doing more than is required for the sake of others' welfare. As an advanced practice provider, this may mean advocating for policy reform, volunteering in underserved areas, or leading health education beyond formal job roles. Paternalism, when professionals or authorities make decisions for individuals or a group believing it's for their own good, even if it limits the autonomy. Public health theory must balance individual freedom versus collective welfare. The theory helps advanced practice providers critically evaluate when paternalistic actions are ethically appropriate. Last, framework for prevention. Public health relies on structured levels of prevention. Primary prevention, preventing disease before it occurs, like with education or immunizations. Secondary prevention, detecting and treating diseases early, like in screening programs. Tertiary prevention, reducing complications or disability, like rehabilitation or with case management chronic disease programs. Now let's discuss a client scenario. That way you can see exactly how each theory will be helpful to your patients. Miss Maria Wells is a 31-year-old female who presents to the clinic today with chief complaints of polyuria and palpitations for 2 weeks. Her past medical history includes diabetes and depression. She has no known allergies. Current medications include metformin and Zoloft. Upon collecting her social history, she reports that she's currently living in her car for the past 2 weeks. She works part-time. She denies use of alcohol and drugs. She also stated that she is currently unable to obtain her prescription medications. The Nightingale approach provides a soothing clinical environment, identifies barriers to self-efficacy, and provides resources to help meet basic human needs. The Rainbow Model will consider how social, economic, and environmental factors like homelessness and limited income affects the patient's ability to manage their chronic illnesses. By addressing these broader determinants through resource referrals and advocacy, the nurse practitioner promotes holistic, patient-centered care. The public health approach will assess both health and social determinants, advocate for access to care, and connect to social services programs.
All three of our theories can be applied to clinical practice and used to create nursing interventions. When discussing Nightingale's approach to quality improvement, interventions can be seen at both the individual and leadership levels. At an individual level, this theory can be applied through providing quality care, meeting basic human needs, and maintaining healing environments. Additionally, this theory helped form the assessment process ADPI, which is used in modern nursing schools and highlights patient-centered interventions with the evaluation of effectiveness. In leadership, Anderson states that the use of a variety of tools, such as flowcharts, cause and effect diagrams, and control charts, can assist with quality improvement. Leaders must also prioritize the input from staff to determine gaps and barriers to performing quality patient care. The Rainbow Model can be applied by assessing patients holistically, considering both clinical and contextual influences on their health. As an advanced practice provider, implementing a holistic approach can be achieved through a comprehensive patient assessment that considers physical, psychological, social, cultural, and spiritual factors. The provider must build rapport and use active listening to understand the patient's unique experiences and values. Assessment findings are then integrated into the care plan, ensuring that interventions address both clinical needs and contextual influences on health. Collaboration with the interdisciplinary team and continuous reassessment can further promote individualized, patient-centered care and improve outcomes.
Public health theory guides nursing practice by emphasizing population-level prevention, health promotion, and reduction of health disparities. In nursing, this means interventions not only limited to treating individual illness, but are designed to protect and improve the health of the entire community. Now let's discuss interventions that could help out our patient using all three of these theories. Of course, you're going to start out with doing a physical assessment and diagnostic testing. Just a few testing that could be ordered lab-wise could be hemoglobin A1C, BMP, a complete blood count. Whenever it comes to physical assessment, let's not forget to assess for neuropathy and do a complete foot assessment just due to the patient's history. Screening tools can be used such as the PHQ-9 depression screening tool. Referrals can be made as for housing. Also, referrals can be made to places that provide community showering and laundry services. Enroll patient in case management programs that will help with chronic disease management. You can also help with a Medicaid application or refer to low-income insurance programs. Now let's talk a little bit about on the leadership level, interventions that can happen. Initiate programs that will provide free hygiene kits or foot care supplies or first aid kits. Starting a support group. Write support letters for expedited housing vouchers. Participate in county public health meetings.
There are some components of each theory that does need some additional research before they can be applied in advanced practice. Nightingale's quality improvement approach has data collection gaps. Data collection and visual aids can be done in a variety of ways, which leaves gaps and possible inconsistency across clinicians and sites. These inconsistencies could be a result of the need for different charts and variances in minimums for collection or invalidation of improvements. Dahlgren and Whitehead's rainbow model has a lack of data integration and technology support. The model was developed in 1991 and does not explicitly address digital health access. Electronic health records often lack fields to document or analyze social determinant data, preventing providers from identifying trends or targeting interventions based on community needs. As a result, research should be conducted on how to better integrate the rainbow model into today's technological-based practice. With the public health theory, a lack of screening tools threatens public health by reducing the ability to identify disease early, particularly amongst the vulnerable and underserved populations. Many screening tools for social determinants of health do exist. However, their implementation in nursing workflow remain inconsistent. This underscores a gap. The absence of standardized systematic approaches to integrating social determinants of health to nursing practice, and the need for research to develop tools, consistent protocols, and measurable outcomes for these social risk assessments. Nightingale's approach to quality improvement in the rainbow model can be used in the development of evidence-based practice protocols. Using Nightingale's approach to quality improvement, evidence-based practice protocols can be created using 4 steps. The first step starts with leadership collecting data through audits, current patient outcomes, and staff input. This allows for the understanding of practice gaps, opportunities of improvement, and barriers to providing care. Secondly, interventions that eliminate these barriers and highlight possible causes for low outcomes must be constructed. These interventions should then be put into practice and evaluation through visual aids that clearly demonstrate efficiency. With this evidence, protocols can be created and proven to be effective. Applying the rainbow model to the development of evidence-based practice protocols involves considering the multiple layers of influence that affect health and care delivery. This model guides healthcare providers to integrate individual, social, environmental, and policy determinants when developing protocols, ensuring that interventions are comprehensive and contextually appropriate. By recognizing how broader societal and environmental factors interact with individual health behaviors, providers can design protocols that are equitable, sustainable, and responsive to the diverse needs of populations. This approach ensures that evidence-based practice extends beyond clinical data to include the wider determinants that shape health outcomes.
When it comes to treating patients, all three of our models are connected. For example, if we took a community of people, we would first use the rainbow model to determine the social barriers that prevent self-efficacy. We can then transition into the Nightingale model and use evidence-based interventions to help create a plan of care. During this plan, we will try to eliminate as many of the barriers as we can and use the collected information to evaluate if our interventions are successful and if they result in positive outcomes. Lastly, we could use the public health model to create programs that support continuity of care and the continuous elimination of barriers. These programs could be parks, shelters, food banks, anything that will help the community get the things that they need.
While the discussed models and theories are widely used throughout healthcare, there are areas that need future refinement or research to be better used in nursing practice. For Nightingale's model, as healthcare continues to evolve, research will be required to ensure the most up-to-date information is considered. The rainbow model is useful, but it needs updating to reflect how the different layers interact in real life. The model shows rings around the individual, but in reality, those layers are constantly interacting with each other. Future refinement should be aimed at long-term studies that model how determinants influence each other over time. Providers will be able to create more effective interventions if the model recognizes these constantly changing interactions, especially in areas like chronic disease management. The public health theory must adapt to the rise of digital data environments by integrating how technology, algorithms, and online platforms influence health behaviors and access to care. It should address digital determinants of health to include data privacy, misinformation, and digital exclusion while incorporating ethical frameworks for surveillance and AI use.
Let's reflect back on our patient, Miss Maria Wells. She was a 31-year-old who came into the clinic with chief complaints of polyuria and palpitations for 2 weeks. Even though she came into the clinic with physical symptoms, upon assessment, we found that she had a lot of social needs that haven't been being met. Applying theory to clinical practice has increased our use of current literature and research findings. For example, Nightingale's theory guided us to studies linking environment and diabetes outcomes. The rainbow model led us to evidence-based screening tools, and the public health theory encouraged us to review community resources and nurse-led intervention research. As a group, theory has influenced the use of up-to-date evidence to guide us in day-to-day practice when providing holistic support, equitable care for patients experiencing homelessness.
In addition to working as a registered nurse, I assist leadership in assessing possible areas for quality improvement as they relate to caring for diabetic patients and responding to hypoglycemic events in the emergency department. Nightingale's approach is used in this role in many ways. This role involves auditing charts to evaluate compliance of already set protocols and using this information to determine if these protocols are out of date or simply not applicable to the flow of the department today. I am also collecting information from staff to highlight barriers to providing care and creating solutions to help these problems. Lastly, all of my collected information, which includes audit results, reported barriers, and proposed solutions, are compiled into visual aids that show clear correlation to patient outcomes.
In daily practice as a triage nurse in a primary care setting, I recognize social determinants by considering all layers to include housing, employment, and access to transportation and healthcare when addressing patients' needs. For example, when a patient misses a follow-up appointment, I find out why the appointment was missed and inquire about any transportation barriers. If transportation barriers are noted, I then collaborate with a social worker to arrange facility-provided or community transport options. I have learned to evaluate my own clinical practice by looking beyond symptoms to consider social, environmental, and economic factors affecting each patient's health. By implementing a holistic assessment when triaging, I can ensure that care decisions address both immediate clinical needs and the wider determinants of health. In conclusion, Nightingale's quality improvement approach, Dahlgren and Whitehead's rainbow model, and public health theory collectively shape and strengthen advanced nursing practice by promoting holistic, evidence-based care. Nightingale's focus on data, observation, and environmental factors guides nurses in improving patient safety and outcomes through continuous quality improvement. The Rainbow model expands this perspective by emphasizing the social, economic, and environmental determinants that influence health, helping nurses address inequalities and design interventions beyond the clinical setting. Public health theory reinforces prevention, health promotion, and population-based strategies, empowering nurses to advocate for policy change and community wellness. Together, these models enable advanced practice nurses to integrate individual care with system-level initiatives, fostering equitable and sustainable health outcomes.